Well, I'm just going to move right across then. So, I mean, you're saying you have concerns, you think it would have an impact on professionals doing their job?
Thank you, yeah. And it's a really good point. Our concerns are that clinicians on the ground who are facing those decisions are human beings, and equally they have their own fears and concerns about their own practice. And our concern would be which might then result in adverse outcomes for themselves. We don't want that pressure on somebody. We want them to make the right decision for a patient. So we think that it might have an unintended consequence of a clinician not making the best a decision in the best interest of a patient. So we're concerned about that.
Okay. But, I mean, if the clinician was making a decision in the best interests of the patient, surely that should be protection enough.
Well, we think that an organisational responsibility would already have that, because any investigation done by an organisation has to include individual and relevant clinicians. So we believe that that organisational duty will cover all of those responsibilities without having the impact that we believe that that holding an individual responsible directly would have.
Okay. So, I mean, obviously the department have put this in the clause in the bill. Have you had any engagement with the department in relation to your concerns, and are they prone to taking on those concerns?
We have definitely had engagement with the department. We originally submitted evidence in 2021, I think, when legislative options were being considered, and then we submitted evidence again last year and had a meeting with the department then. I think we've focused a considerable amount of our conversations with them to date on the confidentiality points, because I think this point about naming individuals came up a little bit later, so I think our conversations on that point are probably ongoing.
Okay. So, and then sort of going back a wee bit then in relation to the kind of concerns that have been raised previously at this committee about the definition and whether GPs, I think, was raised it about reporting about people at risk. I mean, you are less concerned about that. I think you said there could be a more nuanced approach in relation to that. Could you maybe just explain that?
I'll kick off, and Cathy may want to come in as well. We think that every case is unique, and with a complex scenario like we would describe or expect in this, I think there needs to be judgments made on each and every case, even those who don't have mental capacity. Even then, you need to make the right decision for that person at that point in time. So having the professional judgment as part of, if not in the bill itself, but in part of the code of practice that should be attached to it, or any statutory guidance that's attached to it, I think that, or we think that that's really important to include, to allow those professionals who are the ones who are exposed to this most of all and most of the time, to be able to use their experience, their judgment, and to talk to their colleagues to come out with the best decision for that individual patient.
So, I mean, there's a distinction in the Scottish bill. I mean, is that something that you think would be helpful in terms of the made between an adult who is unable to protect themselves, deemed at risk, and an adult who is unwilling to protect themselves?
So I think in terms of the exact wording, we would sort of be open to different options. What's really important to us is that somewhere there is space maintained for doctors and other professionals to make their own judgments. That's the key point, really.
Okay, thank you very much. I'm just going to go on to other members. Nola?
Thank you. Can I follow on from that last question, actually? Just to explore that a little further, in terms of needing space maintained for clinical judgment, which of course we respect. It's obviously very important. Would you be able to give us examples for those who normally or typically usually have capacity, and that you still would need that clinical judgment, and you'd be concerned about it being restrictive, that it couldn't include them? Would you be able to give us a real kind of life example?
So I think I can probably talk about something that we did when we were thinking about our confidentiality guidance last time. So when we last reviewed it, this was one of the things that we thought really, really hard about, because I suppose one of the situations that we might be thinking about is people who are, for example, in an abusive relationship. They may have capacity, they may be able to make their own decisions, but they may be under sort of quite considerable coercion or pressure. And in that round table, we heard we spoke to a number of different organisations and people who had lived experience of that sort of situation. And one of the things that came through really, really clearly in that was that finding safety is a process, and that building up trust and sort of, having conversations, hearing about different options for support, perhaps signposting to other organisations, thinking about risk assessment, all of that is really important. And it may be that at the end of that process, some information might be shared, it may not. I think in our guidance, we say that in those sorts of situations where an adult patient has capacity to make their own decisions, our registrants would usually abide by that, by their wishes. So there may be some very exceptional circumstances where the risk is so high to that patient, and it's a bit different if there's other people at risk. So we're really just talking about situations where there's only the one person at risk. There are very exceptional circumstances where it may be that information would need to be shared. So, for example, very serious crimes, risk of murder, or very serious assaults. So there is still space for doctors and PAs and AAs to share information in those circumstances, but we would expect them not to be doing that by themselves. It's a really difficult decision to make. It's very important to kind of weigh up that sharing information against someone's wishes, their autonomy, what is for the best. It's really hard to tell in those circumstances. So we would expect them to be seeking other expert input, to be talking to more senior kind of expert colleagues as well.
I was thinking about the possibility of the coercion or non-physical abusive nature, which I know can be covered in other laws, but do so kind of for myself to keep it just as an example. If we were to use those unwilling to help themselves, would they fall into that, or is it not really enough because they can't?
It would really depend on the consequences of it. If by not referring there was a risk, a significant risk, then you have to make one decision. If by not referring somebody who had capacity, there was no risk to anyone else or to that person, then you would say, well, there probably isn't a point in referring that person. And your duty of confidentiality to that person will then outweigh that. I mean, that's a really important point about duty of confidentiality. It's the basis of the patient-doctor and patient-clinician relationship. And if you lose that, particularly in these days of social media, you can lose trust in the medical professional in one instance. And that's, I think, a real concern for us, that if you lose that trust, it can become a really big issue for that one clinician or even that practice or a hospital, because a decision has been made which hasn't gained the consent of somebody who has mental capacity.
I think that's helpful for us then, and also not just the confidentiality, but the definition as well. Something for us to think about after. And I have another question on the statutory guidance that you say is needed, and the professional judgment is used in making referrals. And I just want to draw a correlation then with children's services and making referrals to children's services about under 18s, minors. Is there, whilst it might be simpler, but is there statutory guidance for that as well? So is it something that's actually just been done before? And is there statutory guidance?
Children?
Yeah.
I think we've really considered that.
I'm just thinking, is it necessary? If
Well, children are, in many ways, you have to think about differently because of guardianship, parental concerns, parental rights, and who makes the decisions for them. So I think there are, you almost need a different set of rules.
I know it would be different. I'm just saying, is statutory guidance something that is always required? It's just that you you want it there to kind of assist in.
Well, I think statutory guidance in that circumstance would be really helpful as well, because like in adults, no single situation will be the same as another. Everything will be unique. In medicine, we have books on respiratory medicine, books on cardiac, and books on gastrointestinal. Nobody tells you, nobody writes a book of every single one together. And the same applies to everybody's individual circumstances as a patient. Their positions are unique, their social circumstances, their financial circumstances, their cultural circumstances, and their circumstances alongside the people around them. So I think that's why we think it's very hard to make very firm rules on this.
Okay, that's helpful. And I want to ask, with regards to the other jurisdictions, you've mentioned Scotland a few times. Are there any lessons that are to be learned in the other jurisdictions that you could perhaps share with us outside of what has already been brought up here today?
We can talk about what we've had from outreach, couldn't we?
So we're not aware of any issues sort of arising that we have heard about through our outreach teams or through our we've got like an ethical inquiry service. We don't have anything that's been raised with us that suggest that there are difficulties in how that legislation is working. So I suppose as part of when we were looking at this bill and we've been thinking about it, that's one of the things that gave us some reassurance to think that if it's working well in those jurisdictions where it is quite similar legislation, but there is clear guidance and codes of practice that sit alongside that legislation, which is where that kind of detail is given.
Okay, that's helpful. Thank you very much.
Thanks, Nola. Danny?
Thank you, and thank you for your presentation and your submissions. Neither of your written submissions addressed CCTV provisions. If the appropriate measures under Article 8 were met, what is your view on the use of CCTV as a safeguarding tool, and what safeguards would you expect to see in legislation and or in guidance?
May I go first?
Yes, please.
Thanks very much. Our role as a regulator, as you'll be aware, is in terms of regulating individual professionals, and it doesn't extend to systems regulation, I'm sure you're aware. So we don't have a formal position on the development of regulations or guidelines within this area. But we would note the mandatory use of CCTV and or body-worn cameras in care settings would need to be considered very carefully, balancing privacy, particularly consent in residential areas and or private home settings. We do consider that clear proposed benefits might need to be set out against privacy and human rights implications, particularly where CCTV is being used in private care settings, and a discretionary option could therefore be preferable to ensure decisions are taken in a balanced manner with due consideration of privacy implications for people using services. We think there's also considerations about decision making in this area for people without capacity, of course, and one could argue either way that CCTV could be helpful in that scenario. But nurses already act in line with the Northern Ireland Mental Capacity Act of 2016, and further guidance will need to be clear about how decision making about CCTV, in line with the Adult Protection Bill, interacts with existing legislation. Of course, as a regulator, the use of CCTV footage could be very instrumental in either exonerating practice or in supporting fitness of practice referral. But of course, we're aware that the absence of lack of care or examples of bad care on CCTV doesn't mean that bad care is not occurring. So it is a challenging scenario. But we would just ask that where it is used, that organisations have robust governance in place to ensure footage is appropriately retained, reviewed and disclosed. There'd also need to be clarity around which organisation is responsible for approving and overseeing the implementation of these arrangements. And clear protocols should set out in our advice where footage should be escalated, how it's preserved as evidence quite crucially, and how it's shared securely with relevant bodies who need to see it, including regulatory bodies. It helps to ensure that any concerns identified are translated into timely and well-evidenced referrals, supports fair and transparent fitness practice processes, and avoids situations where potentially significant evidence is unavailable or cannot be relied upon due to poor handling or retention practices. And we do rely on evidence being shared with us so that we can take proportionate actions against registrants under investigation. And we think that reciprocal sharing arrangements enables us to fulfil our statutory duties and in turn enables local systems to be assured that appropriate safeguarding mechanisms are in place. So it's a challenging situation, I understand that.
That balancing of rights
I would say
of
so.
privacy. Yeah.
Thank you.
Thank you for that. Anything you'd like to add from
Well,
GMC?
very briefly, we think other organisations are better placed to comment on this, and in Northern Ireland, the RQIA, we think would be the right body, and it should be a system decision rather than an individual decision for a regulator. Having said that, we do have guidance and advice in our GMC codes, good medical practice guidance, that's relevant to making and using audio and visual records of patients. So it's not something we're against in using it, and it is something that we would consider in fitness to practice procedures as well. So, but we do think that it's the decision on this sits elsewhere.
Can I take it back to clause 2? I just wanted to ask around the wording of clause 2 and the definition of adults at risk, and where capacity sits in that. Now, in particular, can you accept the wording, or I know we have the example that Philip mentioned about in Scotland about patients who are unable to look after themselves against patients who are unwilling. Do you think the wording needs to be strengthened there to reflect the capacity of the person involved?
Thank you. Do you mind if I-
Please.
Thank you very much for that. Again, each situation stands on its own merits, doesn't it? And you can be capacitous for many reasons, but when you go into healthcare, that capacity is diminished. Your mental state can fluctuate, and that's the case for many people. And so I think vulnerability and safeguarding in relation to individuals is very much fluctuating. So depending on the circumstance, depending on the support, and I think that a broad-based definition would give that latitude for people to act within a broad base. I think the dangers in having very, very strictly tied down definitions then makes legislation quite narrow, or can be narrowly interpreted. So I think for it to apply in a multitude of circumstances, contexts and circumstances of care, it should really be as broad as possible to allow for that individual context building and professional decision making. Thank you.
I'm not sure we've got a great deal to add to what Donna said, to be honest. I think that point about not wanting to have sort of a blunt instrument where the definitions are sort of too strictly outlined, where you leave that space for judgment, I think is where we would also be wanting this to go.
Thank you. My last question, just about the Adult Protection Board that is mentioned, and just about how you feel, how independent the Adult Protection Board needs to be in order to function properly.
We very much welcome the establishment of the Adult Protection Board for Northern Ireland as a real mechanism for strategic risk and overview of the work to protect adults at risk. And however, as a regulator of professionals, we do not have a formal view on the specific structure or remit of the board, but it would be important to ensure there are effective mechanisms for those closest to areas of risk to escalate issues at an early stage. It will allow for proactive information sharing, and again, that might be a strategic view, so that action can be taken if necessary to protect the public. And I think it's about striking out inconsistency of approach and making sure you have an all Northern Ireland approach, which is really helpful. We'll very much welcome any further detail about how you envisage the board will function in practice, and how information sharing, in particular information sharing and collaboration across agencies, as we've mentioned already, with the use of CCT and other information, could be facilitated through the board, particularly in relation to high profile cases. Thank you.
I think we're aligned to that position.
Thank you, Chair.
Okay, thank you. Linda?
Thank you, Chair. And Nuala and Danny and yourself have covered some of the points. I mean, I think that in terms of the definition, I probably agree with you, because just given our own experience around recent issues with coercive control, and I think specifically to the Katie Simpson case, and the fact that she had attended NA, I think, on more than 20 occasions, but I think it was significantly more than that, and her abuser attended every time with her. No report was made, and he murdered her. So I think that there are definitely are issues there that we need to keep an eye to. Just on the last point in relation to Danny's question around the board, do you think, I know you've said you would appreciate an update, but do you think you should actually be consulted, that they should be speaking to you about what that should actually look like and what they should do, and I think that speaking to you after the fact could be a problem, because if there are issues then trying to reverse things can be more difficult.
Thanks for your question. I think that, a clear terms of reference with escalation mechanisms within the development of the board would be really helpful. We'd be at your service to support you and, in developing that approach, because you're right, if we try to reverse engineer something that doesn't fit and our legislation doesn't mesh, then it's challenging, isn't it? So we all want the best for people, and we'd be very grateful and happy to support in development or commenting on your plans for the establishment of that board.
Okay, thank you. That's my other issues been covered. Thank you, Chair.
That's the same for us as well. We're here to assist you, look after your patients, and we're in the same ballpark.
Donna?
Yes, thank you. So, just back to the Clause 4 issue, if I may. You said that the Clause 4, if I've picked you up correctly, and if not, do sort this out for us, that the duty to report and the potential conflict with the duty of confidentiality to your patient is an issue in Clause 4. But you say that there is scope for individual professionals to make judgments within Clause 4. And I'm thinking of the statutory guidance that might accompany Clause 4. How would that be codified, or is there a need to codify it? Or if we don't codify it, does it leave too much not really tied down on the issue? If that's a good way of putting it. Probably not, actually.
So in terms of our understanding of Clause 4, I think it's probably fair to say that it's evolved a little bit over time. So when we first started looking at this, we shared the concerns that have been raised in committee before about the tension with confidentiality, and we raised those with the department. We put that into our written evidence. I think as we've further scrutinised it and we've compared it to what the situation is in Scotland and Wales and how that's working in practice, our understanding now is that it could be a little bit more nuanced than that binary approach of if somebody meets this definition, you must report, because there would be those other factors that might need to be considered that Push mentioned in his opening remarks around sort of convention rights and our professional guidance and the right to privacy and all of those other things. So our understanding at the moment is that there would be some scope for that. I think having something that makes that really clear would be very welcome, because it is really important that people don't read this or sort of hear about this legislation and think, I must report in all circumstances. I guess that's what we would want to avoid, and to make it clear to people that there is still this space for judgment. And I think, perhaps in that statutory guidance, working through maybe some scenarios or case studies and sort of talking through the steps that a professional might take when they're thinking about whether or not information needs to be disclosed would probably be something that would be really helpful, because these aren't easy decisions. They can be really complex.
No, I completely accept that, which is why I wanted to know, do you need a more specific use of language in relation to it? We're not going to get a second crack at doing this bill, so we need to do the best we can to make sure that for both the clinicians and for the patient or that person potentially at risk, that it works as well as it can, which is important. Can this is probably just a comment rather than a question. I've listened now to a number of people present in relation to the use of CCTV, and almost invariably I've got the same answer, I think, from everyone, which is sort of, well, you know, it has to balance rights and harms, etc. But I haven't found anyone that's willing to give me a more specific sort of line on it than that. I personally worry about it. I can understand for people who have come through that system and there has harm been done, why you would want CCTV. But there are many people living in care homes or wherever, wherein that room is their home. And it's really important that balance of privacy and individual rights is also respected. So I'm struggling with this aspect of the bill, quite honestly, and I'd really love somebody to come in and...
I don't think I could answer that question. But,
give me more of an answer.
My father was in nursing care.
Yeah.
And he had this habit of getting up and walking around when he wasn't steady on his feet. And he was found several times fallen in his own room. Now, in his particular case, his mental capacity changed every time he got a waterworks infection. and that's when these sorts of things happened. So what would be the balance there? Have CCTV to prevent him fracturing his hip and going into hospital and using lots of resources, or not have CCTV, have CCTV to prevent that sort of thing, then not have CCTV and risk those things. It's a balance of risks and it's very, very difficult. So can't answer your question, but I can see lots of applications where it could be discussed on an individual basis, like we keep saying, with judgment and so on like that.
Thank you, Chair.
And could it be, I mean, because I think we would probably all share Dan's concerns about, you know, the home being, or a care home and bedroom being that person's home, but it kind of is the same conversation that we're having previously about whether the case to report, you know, that sometimes there are competing risks, and I think the job of the legislation is to find the answer to those competing risks in that scenario as well as the reporting scenario.
I think it is about a balance of approach and risk, and as it's been mentioned, people's condition can fluctuate over time, or sometimes for short periods of time, as Push has already said about a specific infection, and then once that's treated, the person is more capacitous going forward, and it is a real challenge. And I suppose it's for that management of risk and for caregivers to think about how they manage that risk, perhaps balancing the needs of the individual with the staffing complements or the environment they live in, etc. And I'm sorry, I can't give you a direct answer either, but I think it's very clear that the notion, I mean, we're not just talking about CCTV, you've now got the smart glasses where people can record you without you knowing much about it. You know, I think, again, if you limit, perhaps with respect in your legislation, to CCTV, you risk not future-proofing your approach. So you maybe want to talk about, I guess, recording devices or surveillance in its wider sense than just CCTV, just a thought. But I think that it does have its place, and it's, again, it really is about balancing that privacy and the management of risk.
Leah?
Thank you, Chair. Just to go back to Clause 4, so in the evidence that was provided by yourselves, the GMC had stated your opposition to the naming of individual professionals within Clause 4 because that would then be inconsistent with legislation in Britain. But in contrast then, if I'm right, the Nursing and Midwifery Council would support adding nurses and midwives as named professionals, obviously given that you would have the proper statutory guidance in place. So maybe just a wee bit of feedback on those sort of varying positions.
Let me speak. Thank you. I think that, as I say, we already have those responsibilities within our code of practice at an individual level, and you'll see perhaps in other countries where they've had, for instance, the duty of candour legislation as well, and that translates, whether or not it was only in Scotland initially, it was still required of all registrants across the 4 countries of the UK by virtue of it being a requirement within our code of practice. So there are different ways in which legislation can sometimes be a blunt instrument, but the professional codes clearly take context into account, and as I I said already, in terms of education, underpinning standards or proficiencies and ongoing revalidation processes, people have to show how they maintain their practice in line with the code. What we're not saying is it's an absolute requirement for people to report. And again, very much like colleagues at the NMC, it's about context, about supporting nurses and midwives and nursing associates in England to understand, balance the legal and ethical requirements, think about the context within which it's happening. And again, that particular circumstance where colleagues have mentioned about that broken trust or preventing people coming back for further healthcare, it's a balanced and nuanced decision, having the patient always at the centre of the best interests. So whilst it's a requirement to consider and safeguard right throughout our proficiencies and our standards, it is context specific and balanced on the professional judgment of the individual professional.
Okay, and maybe it's just on the issue also around the evidence session that we done with the GP stakeholders before Christmas, and then this issue of capacity, and they were very clear that in terms of the rules and regulations that they abide by as clinicians, that people with capacity should have the right to make their own decisions. And I'm just wondering have there been any conversations between yourselves and GP colleagues in terms of, because obviously you're giving us different feedback?
No, but they are our registrants. Mm-hmm. And
yes.
And the other thing I would say about individuals, I think that question is about accountability. Mm-hmm. And my only concern is that in an endeavour to make sure that accountability happens, you might lose something as part of that. So I think I also think the accountability is already there, as long as we have an organisational responsibility, and that organisation, I would expect them to do a thorough investigation of anything that came to be, which includes all healthcare practitioners, including doctors, and our other registrants. So that's sort of our view on that. But and I think it is also consistent with the other devolved nations in that respect.
Can I just add something on the point about sort of the potential differences between our position and that of our colleagues at the BMA and the RCGP? I think we're coming at this from a place of the same concern. So around this being about centering the patient and making sure that their wishes are taken into account. I think where we differ a little bit is what we think the solution is. So I think colleagues from those organisations have argued that if we remove patients with capacity completely from the legislation, that would resolve that concern. I think there are a couple of reasons why we think that making clearer that there is still professional judgment for both patients with and without capacity would be a preferable option. One of those is around the sort of the coercion point, and the point where somebody may have capacity but there may be a really, really high risk to them. Another is that, and I think Push mentioned this before, so for patients who don't have capacity at that point, there still needs to be a balancing of the different factors and a decision made about whether referring is in their best interests or not. So yes, in most cases it probably will be, but there may be circumstances where it isn't for all sorts of different reasons. And so if the legislation is interpreted in a very binary way, if somebody meets these definitions then you refer, and if somebody doesn't meet these definitions then you don't refer, that takes away that professional judgment element for those without capacity as well. So that's why we've sort of come to the conclusion that actually professional judgment for patients with and without capacity is a preferable way to go.
And that is how it works in Scotland and Wales?
Yes, that's my understanding, is that in both Scotland and Wales, they have a very similar approach. Mm-hmm. And that in the codes of practice or statutory guidance, I think that they're all slightly different, but the sort of accompanying information that's for professionals makes that really clear, that decision So this legislation, or the legislation in Scotland or Wales, isn't the only factor that someone is considering. That it's something that's in the basket of all the different things that they're considering, including legal duties around confidentiality, common law duties of confidentiality, our professional guidance, Article 8 rights. All of those different things are sort of coming together to then make a decision.
Can I just add that even if you don't refer, it doesn't mean you don't do anything. You still have a load of activities you can do for those who have capacity, where you can point them in the direction of supportive help, third sector support, and information that might lead them to change their mind. And those without capacity, even if you didn't, it doesn't mean you're not going to consider that patient and not have safeguarding meetings about how to protect them and how to support them. So I think there's want to get away from the idea that it's one or the other and that's the end of it. It's not. There's lots of things still going on with those individual patients.
Okay.
Wanda?
It's just a quick point for ourselves, Chair, I think, to have in our own heads. I've had experience, I'm not sure if this is across the board, and maybe it's something we need to actually find out, but I have had experience where the assessment of capacity has been severely delayed, where there are real delays in that assessment process, so you could have a number of people actually waiting. So that's another issue we need to consider if you're going to bring the definition, which I don't necessarily think we should, to capacity and being assessed as actually not having capacity, because if there are delays in that, you could have people who don't have capacity just haven't been assessed yet, and we're putting them in danger and putting them at risk. So it's just something for us to have for ourselves rather than a question for yourselves. It's our issue, not yours.
Okay, thank you very much. Alan, sorry.
I had a couple of quick fire questions. Thanks. One of the frustrations that I have had on here, and I think all of us share it, is that there is a very high likelihood that this piece of legislation will not be fully funded. At best, it will be a slow, phased implementation, and potentially at worst, it'll be a partial implementation. What would be the challenges that you would see in a slow, phased implementation, or worse, a partial implementation?
Well, literally off the top of my head, I think that it would create uncertainty.
Absolutely.
And if you have uncertainty, then at every decision you've got a patient at the end of it that you've got to make a decision about. And if you're making one decision based on one set of rules and another decision on another set of rules, you will end up in a real mess.
Can I also just ask, there was reference made to the Adult Protection Board. I think Danny had raised it, and I know I've raised it with other organisations that have been here. Do you feel, well, given the importance or the important role you play as independent regulators, do you feel that you should have a seat at the table, or do you prefer
a seat at which table? Sorry?
At the Adult Protection Board, or do you feel that that would compromise your own independence?
I don't know.
I think possibly the latter, with respect, just off the top of my head again, not having had a chance to really consider that. I think that where we would have a clear separation in our duties, then obviously then would we have a conflict in relation to hearing fitness practice cases if we had been party to information that might muddle those waters. I think that in times of the implementation of the bill, it would give time, even if it is elongated, to develop that guidance, to test it, to train, to bring hearts and minds along with you, rather than a quick or a clear implementation timetable that brings all the elements of the bill into place in one time frame. So often it's often the case with legislation, it's implemented in parts and learning from each part of that implementation process. The next one, an example in mind, comes to Scotland, is the Human Slavery and Modern Slavery and Human Exploitation Act, and that's been implemented in parts and learned. And again, these are relates to people who have been enforced into areas of work that they, on the face of it, are capacitous, but that the pressure that's brought to bear on them is clearly vitiates then their capacity. So I think in Scotland we learned from the stepwise introduction of that Act, and it really did help us to get it right as we went through. So there are advantages and disadvantages to implementation in a delayed or stepwise fashion.
Okay, thank you very much. That has been extremely useful, both the oral evidence that we've heard, but also your written submission. So appreciate you coming and giving us the time and answering our questions. Thank you very much.
Thank you.
Okay, members, we're going to the next item then, which again is another oral briefing on the Adult Protection Bill, this time from ARC, Volunteer Now and Hourglass. Can I refer members to our papers, tab 16, page 135. Just going to welcome Miss Denise Hayward, CEO of Volunteer Now. Sorry, I've got 4 names down here. I'm just waiting. There's other 2's coming on now. In case I'm reading names. So, so Miss Ruth Mulholland, Safeguarding Manager of Volunteer Now. Mr. David McClure, External Affairs Lead of Hourglass, and Miss Donna Johnston, representative of ARC NI. So, you're all very welcome. We have received your written submissions, so thank you very much for that. I'm just going to hand over to yourself just for some brief introductory remarks, and then we'll take questions from the members. So I don't know if you've agreed a process.
No.
Go ahead.
I go first. I'm Denise Hayward. I'm Chief Executive Volunteer Now, and I'd like to introduce my colleague Ruth Mulholland, who's our Safeguarding Manager. So for those of you who don't know us, Volunteer Now is a regional organisation that supports volunteering across Northern Ireland, and I know we've engaged with a number of you on other issues before this. So I'm going to hand over to Ruth to kick off our remarks, and then I'll wrap it up.
Okay, thank you very much for the time this afternoon. We're delighted to be involved in this conversation. We have looked through the bill and addressed the main issues that we feel need a bit more discussion, and we're just going to work through those now. All organisations delivering services or activities for adults have a duty to safeguard them whilst they are in their care, and it is crucial that they have robust adult safeguarding policies and procedures in place. This applies to all organisations across the statutory, independent and voluntary and community sectors. Since 2009, Volunteer Now has been providing safeguarding and volunteer management support and training to all sectors, helping organisations operate to the highest standards. We also deliver services to older isolated people through our volunteer-led befriending, shopping and driving projects. We therefore understand the importance of a robust legislative framework for adult safeguarding in Northern Ireland, and we very much welcome the introduction of this bill. Anyone who harms an adult in their care, regardless of their role, whether it is paid or voluntary, should face appropriate sanctions for doing so. However, we do have some reservations with regards to including volunteers within this bill, which we feel require further consideration, and we will work through these points now. Generally, most voluntary and community organisations running services or activities for adults have an awareness of adult safeguarding and the standards required. They have safeguarding policies and procedures in place and avail of adult safeguarding training. While we must never be complacent about adult safeguarding and regular reviews need to take place to improve practice, there is good practice in place within the sector, and this can continue to develop. If a volunteer harms an adult they are working with, there are already procedures and mechanisms in place to deal with this appropriately. Most organisations are aware of the need to report adult safeguarding concerns to their adult safeguarding champion within their organisation and to external authorities where relevant. And where the threshold has been met, criminal proceedings and prosecutions can take place, and or referral to the Disclosure and Barring Service where referral criteria has been met. It is unusual for volunteers to be included within a legislative framework as they are not employees. There is no formal contract drawn up between the organisation and the volunteer. The relationship between the organisation and the individual is very different than that with a paid member of staff. It is a gifting relationship, which makes it more difficult to legislate. A volunteer role cannot be equated to that of a paid care worker. Volunteers in health and social care environments do not have the same level of responsibility as paid care workers. These types of volunteer roles are generally light touch, are in place to complement the delivery of services and to bring added value, and this should remain. This is very different from the role of a paid care worker.
Thanks, Ruth. We also know that there have been quite a lot of changes in volunteer numbers since COVID in particular. Since initially after COVID, we saw a drop in volunteering from roughly 28% of the population of adults in Northern Ireland down to 17% and then up again to 21%. We're back up to 28%, but it is clear looking at the data that the attitude and engagement for people has changed around volunteering. People are not giving as much time. They're more likely to do lighter touch roles than some of these harder roles to recruit for. Particularly, they're interested in less flexibility, less bureaucracy, and so therefore the kind of role that we're talking about here, they're more challenging for organisations to recruit for anyway. We already know as well that there are not huge numbers of volunteers working in this space. It's not the biggest by any means number of volunteers. So sport and faith-based sector tends to be both. In this case, you're talking about roughly 16% of adults who are volunteering working in this space. We also know from our recent volunteer, we did a survey with befriending organisations which we launched in Stormont just before Christmas. We know that people are leaning more towards the short-term roles, and they're finding, organisations are finding it more difficult to engage volunteers who are having to make a regular weekly commitment, which these kinds of roles tend to be. So on top of this, the recruitment process we're hearing can be more bureaucratic, and also the concerns around access NI and accessing those checks, particularly using the new ID system, has been challenging for some organisations. We also know that older people tend to be more likely to be volunteer befrienders, and they do struggle with some of the procedures and the bureaucracy perhaps a bit more than other people. So I suppose what I'm trying to say is there's a context to this. If you put volunteering in this space and make it feel a bit more bureaucratic, there is a risk that that could further damage the numbers of people coming forward to volunteer. However, we are clear and we do understand the need to protect people, and so we're not saying that volunteers can't be included, but what we're saying is that we need to look really clearly at what the definition is if that's what you choose to do, and therefore, you know, we need to think about what the regularity of contact, you need to think about the kinds of roles that you're considering, and not just make a blanket assumption that all volunteers potentially in this space should be included. We need to think about, you know, the setting, whether it's in a residential home or in a hospital setting as opposed to community settings. You need to think about some of those things as part of putting this legislation together. And again, when you think as whether the volunteer is providing a service on behalf of a contract that's delivering for a statutory partner as well, you know, so sometimes that does tend to be the case. I think organisations and groups will need training and support to see where their volunteer roles are going to be affected by this legislation as well. I suppose in summary for us, we need to think about balancing the needs to encourage people to volunteer and to get involved and to support older people and adults at risk in their community against the bureaucracy that potentially could ensue as a result of this kind of change. But we're very happy to support as you think about this and answer any questions, and also to support as it's rolled out. So thank you for the time today.
Okay. Good afternoon, committee members. Firstly, I'd like to thank the committee for inviting Hourglass to give oral evidence on the Adult Protection Bill today. I'd like to start by giving some context of who Hourglass are and what we do. Hourglass' mission is simple: to end the harm, abuse and exploitation of older people. Every year, more than 2.7 million older people across the UK experience physical, sexual, emotional, psychological, economic abuse and neglect. This number has been increasing year in and year out, and this is truly a damning indictment of how society views and fails to value many older people. Hourglass is the only UK-wide charity dealing with these issues, and in doing so we operate a 24/7 helpline for older victim survivors, their families and care practitioners. When looking into the bill, Hourglass would like to highlight a number of areas that we are pleased to see progress on, such as the duty to make inquiries, powers of investigation and entry, independent advocacy, duty to cooperate, access to financial records and new offences. However, there are other areas where within the bill that Hourglass feel have fallen short. First in regards to the principles, Hourglass feels it is positive in saying that the outlined principles in the bill respect dignity, safety, accountability and the best interest of adults of risk. We are, however, disappointed that a narrower scope has been drawn compared to what was outlined in our consultation response, especially concerning a lack of focus on prevention, no explicit mention of regard for older persons, and no indication on the UN principles for older persons. So that's independence, participation, care, self-fulfilment and dignity, as opposed to similar existing references in Scottish and Welsh safeguarding measures. For this, we've already shared an amendment with the committee pertaining to the principles in Hourglass's response to the Adult Protection Bill consultation. Regarding the adults and risk and definition of harm, Hourglass is disappointed that the needs for care and support, whether or not the authority is meeting any of those needs and life circumstances, are not included within the definition of an adult at risk. As we noted in our consultation response to the bill, the proposed bill in 2021, we think that the inclusion of life circumstances provide a greater understanding of capacity to understand the intersections of different characteristics and circumstances and how these impact individuals, especially older adults. The definition in the Care Act 2014 looks at where an adult has needs for care and support, whether or not the authority is meeting any of those needs. The highlighting of the need situates adults at risk in relationships that make up their networks. Sadly, Hourglass knows that it's within relationships, particularly relationships, trust, dependence and interdependence, where personal circumstances and personal characteristics and individual circumstances are exposed to abuse, neglect or exploitation. Personal characteristics and individual circumstances compound power, and it is the interplay of power in interpersonal relationships that can turn into a source of harm. Hourglass is concerned that the omission of the needs for care and support risks narrowing the number of adults who qualify for protection. Regarding harm, Hourglass is concerned that the definition of harm laid out in the bill leaves gaps in safeguarding through the use of a narrower classification than its Scottish, English and Welsh legislative counterparts, by not specifically covering elements of coercion, exploitation or self-harm. The Adult Support and Protection Scotland Act 2007 specifically mentions conduct exploiting another person. The bill also does not include self-harm under the definition of harm, in opposition to defined harm in the Adult Support and Protection Scotland Act 2007, self-harm, neglect and conduct which exploits or causes fear, alarm or distress. The bill's explanatory and financial memorandum specifically notes that self-harm is excluded but doesn't explain why. Self-harm, exploitation and coercive or controlling can be key elements in the abuse dynamics concerning older people, and their exclusions narrow support, accessibility and coverage from the bill, and with this we've also recommended another amendment. Hourglass is pleased with the measures laid out in the bill to develop an adult protection board, with the provisions to include the production of an annual report to outline the yearly future strategies in a strategic plan, define how member and partner agencies will cooperate, detail findings of serious case reviews and illustrate the effectiveness of their adult protection work in a timely basis. All of these measures help provide accountability, transparency on objectives, strategy and change. However, Hourglass is concerned with the placing of such an adult protection board under the Department of Health direction and oversight, which may limit its independence and autonomy. Furthermore, we support the measures outlined within the bill to mandate that the Adult Protection Board undertakes prescribed serious case reviews. Serious case reviews allow for the analysis of the quality of direct practice with the individual, providing a lens on the challenges within risk assessment, engagement, best interest, decision making and personalised care. They also enable investigation into interprofessional and interagency practice organisational factors that relate to the work of practitioner professionals, and the governance of adult protection boards. However, Hourglass is very disappointed that there's no provision within the bill for a unified and detailed electronic anonymised database of all adult protection serious case reviews for Northern Ireland. Learnings and recommendations from subject access requests risk becoming siloed with the lack of efficient sharing and learning across trust and wider society. Certain ASBs and the Social Care Institute of Excellence have created a repository of subject access requests in England. In Wales, the Welsh Safeguarding Repository stores all new single unified safeguarding reviews and allows the use of AI and machine learning to enhance its subjects and analytics functions. Replicated in Northern Ireland, this would ideally enhance the potential of learning from individual reviews by providing a way to share learning across the system, as well as providing transparency, accessibility to a more widespread audience. As such, we have outlined another proposed necessary amendment to the bill to alleviate this issue. In summary, Hourglass is overall pleased with the introduction of the bill, and it is certainly a step in the right direction. However, there's still some gaps that need addressed. In short, the bill lacks a strong focus on prevention in older people, uses narrow definitions that exclude key forms of harm, misses opportunities for independent oversight and sharing learning for serious case reviews. Thank you very much for the committee for their time.
Thank you, Chair, and the wider committee for having me here today. I am Donna Johnston, Operations Director for Positive Futures. However, today I am representing ARC-NI. ARC, the Association for Change, have consulted with its broad memberships and experts by experience to provide the written submission you have already received. I will not repeat the full submission, but instead draw attention to the main issues that ARC believe are most important for today's discussion. ARC has been a critical friend to health and social care within the safeguarding arena for decades and has supported the voluntary sector as a key partner to play their part in keeping people safe. Whilst protection is a statutory responsibility, everyone is accountable and has a key part to play, hence the importance of the independent scrutiny and increased statutory accountability within an adult protection board. We would request that this committee give due consideration to having the Adult Protection Board independently chaired and attended by multiple stakeholders, including the voluntary sector. It is vital that their expertise and experience of the voluntary sector are represented at this forum. The biggest challenge experienced by the sector is having a shared understanding of thresholds and approaches to risk-taking. There is a need for a better collaboration and clarification of the thresholds within the bill, and we would suggest that the committee take this opportunity to ensure the thresholds are fully clarified and understood by all stakeholders. ARC-NI stands up for the human rights of people with a learning disability. Learning disability is a lifelong condition, and people with a learning disability are cared for longer than the typical population. Hence, the impact of decisions made in health and social care need to consider through a human rights lens to ensure the population outside of older people are not disproportionately affected. ARC have concerns that the use of CCTV being regarded as an effective safeguard against abuse, when in reality it cannot prevent harm and may create a false sense of security. At best, CCTV documents evidence of an incident, but it does not negate it. It encourages a perpetrator to identify places that are not covered by filming. CCTV does not foster trust between provider, staff and people supported, but rather breeds a culture of mistrust and threats. The voluntary workforce within health and social care is already feeling undervalued, and this erosion of trust will have far-reaching consequences. Most importantly, the impact on privacy that CCTV erodes needs careful consideration. This is in addition to the huge resource that observation of recordings requires should an allegation be made, and the financial impact of purchasing, installing and maintaining CCTV. Finally, CCTV cannot be forced onto an individual who has a tenancy rights just because they have needs that require support to live an independent life in the community. Thank you for taking the time to listen today.
Yeah, thank you. Dan's not here, but I think she would have been pleased to hear that evidence, just given what she said previously, because that's been the clearest view on CCTV that I think we have heard. So mean, I just want to kind of go back to the some of the points that some of you has made in relation to potentially the bureaucracy impacting volunteers, and maybe the lack of clarity within the legislation and how it would be understood. So, I mean, how does the department either change the legislation or bring in guidance that alleviates some of those concerns about, affecting the volunteer sector, but also allowing for clear legislation that people know what they have to do and abide by, but that it's easily understood by volunteer sector?
I suppose it's quite unusual to actually see volunteers mentioned at all like this in a bill, and if we have seen it before, it's in a very clearly defined setting. So I suppose part of my view would be that, I mean, first of all, I would ask, do you actually need to mention them specifically? Because there's already quite a lot of guidance around adult safeguarding which is impacting on volunteers. They don't have a contract of employment. We've worked really hard with unions over the years to make sure that volunteers are seen as being additional and complementing paid staff, not replacing paid staff. So I suppose it's just thinking that through, and as to whether or not they actually need to be specifically mentioned. If so, then I think it's about being clear about regularity of contact, the kinds of roles that you're talking about, and not just putting a blanket thing in about volunteers. I mean, volunteers don't have a register. There's no nursing and midwifery council for volunteers. So that's, I kind of think, the part of the worry is around the bureaucracy that will then follow some of this, and that the potential for having to create other tiers of bureaucracy, which honestly, if we keep doing this, we're going to be in a situation where nobody's going to volunteer for these kinds of roles. And actually that's a big miss, because volunteers are making a real difference in the lives of vulnerable people and can do so in a safe way, but this legislation may not necessarily help us to do that.
Thank you. No, that's been helpful. David, you talked about the need for stronger emphasis on prevention. You specifically mentioned the UN principles for older people, the creation of a central repository for serious case reviews. I mean, how do you think that would impact, and how do you think it would impact if it isn't included?
Well, I suppose referencing older people and UN principles, it helps anchor the safeguarding in sort of dignity, independence and participation, not just protection. So these principles, they're already guiding approaches in Scotland and Wales. So just including the term would ensure the bill reflects the realities of ageing, dependency and ageism, and it's not just a generic adult safeguarding.
Okay, fair enough, thank you. I'm just going to move around the room now. Nuala?
Thank you very much for coming to committee today. I think actually some of the points that you highlighted, a good number of them are new, which is helpful for us, and it's good to have an adult safeguarding officer here. We haven't had too many at the evidence session, so I'm going to start with yourself, if you don't mind, Ruth, regarding your current practices, if we are to, as a committee, either support the removal of the volunteers in the voluntary sector rather in statutory trust-led. How your own safeguarding practices, do you feel that they are sufficient? How are lessons learned and then altered across the kind of community and voluntary sector, so that we as a committee have confidence that if we were to propose the removal of that we would not be leaving people at risk?
I suppose adult safeguarding really started to have a proper focus around 2005, 2006 probably. And we were commissioned by the department in 2009 to develop minimum standards of practice for organisations working with adults, and there's been a lot of updates and work in relation to those standards, and our role is really to support the sector and other sectors in terms of implementing those standards. We also carry out policy reviews, we train, so we know from interacting with all of those organisations that there is already a lot of good practice in place. Now, as I said, we can never be complacent, and we're certainly not saying that every organisation is where it should be. I don't think any organisation could ever say that. There is that need for constant review and improvement, and it very much is about the organisation taking ownership of that from trustee board level right down, with the likes of our support in terms of doing that. And the key thing in terms of this legislation is if volunteers are put in there, volunteer organisations need to understand the context and the scope of it. And then obviously that has an impact on ourselves in terms of educating those organisations around those. Within our training we already address the legislative context, of course, as part of that, so it would be building on that and helping to explain what this actually means for them in practice.
And so the capacity and
yes.
that might be funding would need transferred
yes.
from the department.
Yeah. Now we sit on the training and development subgroup within the adult protection structures. So part of our role is to inform that group in relation to the bill and what we need to tell organisations, and that is one area that we'll be keen to explore more whenever the bill's in place. But yes, there is a capacity issue in terms of
with regards to the amount, any referrals that you do have to make, or at the minute, I know I'm thinking you're one organisation, but you've quite a wide spread.
Mm-hmm.
Is it something that happens often in the volunteer space? Because people are concerned. Do volunteers, are they aware? Because they're obviously rather live to social issues and social justice, and so they've made the decision to volunteer, so they care. So yeah. Do these happen often?
There certainly is an awareness. In terms of how often, we wouldn't have exact information on that. I mean, in terms of ourselves, Denise, we haven't had to, I suppose, do a lot over the years, thankfully. But they do happen, and the expertise is very much pulled from statutory authorities in terms of those cases. Our information to organisations is where there's any doubt at all that you think this threshold has been met in terms of protection, you need to liaise with statutory authorities around that. You have the duty. We have the Adult Safeguarding Champion and Appointed Persons training, which explores those issues of consent and capacity for those organisations that are more equipped to make those decisions. But some of the organisations we work with are run entirely by volunteers, and there isn't that capacity there. So that's where they would pull in those expertise of statutory authorities, the gateway teams, in terms of what they should do and how they should take that forward.
I think adult safeguarding is still probably the newer of, child safeguarding is much better established, and it's still for some organisations a learning curve, and still organisations are trying to think about where adult safeguarding is relevant for them. For example, even for sports, an example of that. It's more recently that they've started to explore it as something that they need to be considering, whereas child safeguarding is very well established in those kinds of settings. So it is still something that organisations are learning. But I think Ruth's right. We can never say, there's no point in us sitting here and saying, volunteers are never going to hurt somebody. That's not true. But I think what we're saying is the legislation needs to be clearly defined.
Mm-hmm. Thank you. And then Hourglass, I would think the amendments are helpful, for us to consider. Other organisations have also raised the issue of self-harm as well, so we're very much hearing that a number of times. I wanted to ask with regards to the serious case reviews, because we haven't discussed that overly at committee, and you will probably have more your UK-wide experience in how they're actually implemented. And have you found that the implementation of those or its equivalent across any of the jurisdictions, it works well or could be improved, or that any failed or haven't worked well because the bill hasn't been strong enough?
Well, I suppose it's all down to from our experience, those tools that have been implemented in England and Wales, they have led to that learning, which is what we need. So typically 87% of abuse happens in private homes, so you're already at a hindrance there. So it's the hidden harm, and that's where these repositories, I suppose, are beneficial. They do offer that sort of proper anonymisation safeguard, but also improve the transparency, consistency and prevention.
And you mentioned the central repository. We've had this before. We sit in Northern Ireland, the policing board, the police ombudsman reviews often very serious cases, but the policing board is the accountability body and implements a lot of changes and learning, but yet doesn't have access nor gets the sharing from the policing board. So I actually quite understand that and how you could actually learn to move forward. Who would have access to a central repository, and would the intentions be for the likes of trusts to actually implement, you know, changes in the system?
I suppose it would be down to in regards to the Adult Protection Board itself. If they're going to be the ones that are going to be carrying out the serious case reviews, in that essence, it would be themselves. But I think that, I suppose, similar to the ombudsmans, they should be separate, their own entities, to have that full autonomy to go out and explore and not be, I suppose, like there's a risk more, or a perception that the challenge could become constraints. So it's just having that independence to go out there and review these cases.
And that kind of brings me up to my last question then, which was about just checking on what you said, the chair, that the chair is independent of the Adult Protection Board, and I'm genuinely not sure in terms of how the committee will take a view on this issue. It's just worth exploring. Do you mean an independent chair but still under the department?
Yes, we're happy that it remains under the department. However, we would feel strongly that an independent chair is necessary. We would be concerned that there is a conflict of interest, because not only are they commissioner, they're provider. So we would, our preference would strongly be for an independent chair.
Okay, and how does that work in England, Wales, Scotland?
I would have to go and check that and come back to the committee with you.
Sorry, I put you on the spot. I was just checking and just in case you knew. Thank you very much. That has all been very helpful for us.
Thanks, Nola. Linda?
Thank you, Chair, and thank you very much for giving us all of your perspective in relation to the legislation. Just in relation to the principles and the specific principles that you outlined, David, have the department said why they haven't included those principles?
As far as I'm aware, no, I haven't.
So maybe that's just a question we need to ask, given that it is, as you say, in the other in legislation in Scotland and Wales. So we just need to ask that question, I think, probably of officials when we get the opportunity to do that. And do we know what the department's rationale was in relation to including volunteers in the legislation? And just to clarify, volunteers are not included in the legislation in other parts, is that right? There's no specific mention of them, or there is?
I'm not sure about that. Sorry, we've just looked at
Okay,
this.
so I think we need to
maybe it's
understand
something
that,
to
because that would be important and understand. I don't want to assume anything, so we'll just wait and find that out, but I think we do need to understand, is it, and then what was the rationale and how is it impacting
Exactly.
the volunteer cohort, because I would absolutely share your concerns around volunteers, but I suppose, like Nuala, we want to make sure that, look, everybody that's come before us, and I think every member has talked about balance, and this is a very difficult balance because of what we're talking about, and because of the individuals that we're talking about, people who may not have capacity for numerous reasons, and been outlined by all of you, but I suppose specifically, David, in relation to that self-harm and the fact that it's not specifically mentioned. But I think probably that is another reason why we need to keep the definition wide, you know, and not specify it, but it's how do we ensure that those people are identified within that definition, all those people that you talk about. So I think there certainly have been issues raised today that will help us in terms of our questions and conversations with officials from the department. Thank you very much. Really appreciate it.
Thank you, Chair. Thank you for that. Sorry, I had to nip out briefly. I just wanted to ask Donna about your response about CCTV there. Very strong. And certainly we haven't heard Diane, I think we'll be happy with.
I am so sorry. It's just one thing after another this afternoon.
But you were certainly, quite clear in your opposition to CCTV. I wonder, are there any circumstances that you would agree with CCTV being used if there was clear criteria, regulations, strong controls around data sharing, and there was agreement with residents before installation? Would you see that as inappropriate?
Probably as a very, very last resort. I think if you're even considering it as a last resort, you have already failed in your duty of care. I think there's so many other safeguards that could come prior to CCTV. I think probably, McClure has given this sort of false sense of importance around CCTV because it served a purpose there, but it served a purpose in a very set of difficult circumstances that I'm sure none of us want to be in again. And I think it's key to remember that those recordings were covertly got, so staff weren't aware they were being recorded. So as an extreme last resort, potentially yes, but I'd be very concerned if that was even on the table because there's so many other preventative and protection measures that can be in prior to that. And I think it negatively impacts on the person who's at risk and the staff supporting them. And I know there's quite a lot of families who would advocate for it, but again, I'd be very concerned they're not getting the support they need with whatever trauma they've experienced, that they think this is the only thing that can keep their loved ones safe.
Two questions. First, do you recognise any strength in the argument about deterrent, the effect of cameras being a deterrent on abusive behaviour? I know you'd mentioned that potential abusers might find somewhere that there is no CCTV coverage, but the thought that CCTV exists, do you recognise the deterrent factor there?
I think there's a potential that people might, in some sense, behave themselves a little bit better. But I think for CCTV to pick up every area of abuse, it would need to be of a very high quality audio. Abuse isn't necessarily in just the physical actions or even what is said. It's much more complex than that. So I think it might be a slight deterrent, but I think it would be temporary and make the safeguarding referrals much harder in the longer term. And I also would be concerned that staff would feel that cameras are doing their job for them and that the cameras will. They don't need to report something because the camera was there, or even the person who's at risk think it's okay, that's on camera, I don't have to speak up. So I think it would take some of the responsibility off those people to report, to be honest, and to be vigilant.
In terms of other measures, potentially less intrusive than CCTV, what measures would you advocate yourself?
Training. I mean, that preventative, the training, monitoring. Managers being present and monitoring, spot checks. I mean, managers having to sit and watch CCTV rather than actually being present and active in the lives of people at risk. I think it would take some of the time away from that. Proper liaison with statutory bodies, with RQIA, having it at the forefront of every discussion. There's so many proven ways to improve safeguarding practice. The duty of candour. I think there's so many things that we could do a lot better that would improve the safety of people long before you would want to consider CCTV.
Can I ask, as an organisation, do you have a particular view on the duty of candour? Are you in support?
Yeah, absolutely. Yeah.
Yes.
Everybody?
Well, I was part of the working group for the Department of Health a few years ago, following on for the hyponatremia inquiry, and yes, we were very supportive of it at that stage. Yeah.
Thank you. Thank you, Chair.
Okay, thank you very much. That has been very, very useful. It's given us a lot of food for thought. Every session adds something. I'm not going to use the word of complication, but a different slant on it. But it's a very important piece of legislation, and it's very important that we get it right. So this has been very, very useful. Thank you.
Thank you very much.
Okay, members, just moving on then. So next two items on the agenda, 7 and 8, are proposals for statutory rules, SL1s. So just to advise members that a new process for the consideration of SL1s took effect from 5th of January, and that as the first, the first of the SL1s today agenda was received before that date, it will be considered using the old process. The second SL1 was received after the 5th of January, so it will therefore be considered using the new process. In brief, new process aims to strengthen committee scrutiny of delegated legislation. I'll provide some further detail and seek agreement on the new process when we move to the second SL1 for consideration at today's meeting. But in dealing with SL1 on the health and personal social services, optical charges and payments, which was received in December, therefore the old process, can I refer members just to tab 7, page 163, and in our notes that includes the clerk's memo and a copy of the SL1. So, just to remind everybody, this statutory rule would amend the health and personal social services, optical charges and payments regulation for the North 1997 to increase the value of optical vouchers by 4% for eligible patients depending on their financial circumstances to help with the cost of glasses and contact lenses. The Department have advised that there's no estimated cost with the increase and that the Department has advised that the increase carries an estimated cost of nothing and that it is consulted with Optometry NI on the proposal. So, I'm opening up to any questions that any members may have or any comments that they may have. None. So, can I ask members if you're therefore content with the merits of the policy and that the statutory rule is made? Content. Okay, thank you. So item number 8 then, the second SL. So SL1, the Health and Social Care Pension Scheme member contributions. So I apologise at the outset, because this is a new rule, there's a lot I have to read into it, so you'll get sick of my voice in a minute's time, but I have to do it. So this SL is subject to a new process that was introduced on the 5th of January, and we'll seek agreement on the new process before actually moving to consider the SL1 itself. As mentioned earlier, the new process aims to strengthen committee scrutiny of delegated legislation. Departments will now provide information about proposed statutory rules in a new and extended SL1 template. Departments will also provide drafts of the proposed statutory rule and explanatory memorandum within the SL1 paper. The SL1 and all department papers will be published on the committee website, so they'll be open to the public. Committees will now call for views on the proposed statutory rule through an online survey, Citizen Space. This is a short 3-question survey that will ask for views on the accuracy and completeness of the proposed rule and whether there are any unintended or unanticipated consequences associated with the proposal. Committees will not formally consider the SL1 until at least 4 weeks after it has been submitted by the Department to allow the committee time to consider any additional information and views it receives. So, on the basis of that, the committee is therefore asked to agree the following. Agreement to issue the survey. The committee will have to agree to issue a call for views on each SL1 using the standard survey and to publish the SL1, the draft SR and any relevant documents from the Department on the committee website. We'll also need to seek agreement to get information from the Department. The committee will be asked to agree that committee staff seek information from the Department where necessary on any matters raised during each SL1 stage, including in the survey. All information provided by the Department will be provided to the committee to inform its decision making on the proposal. And then also we will be asked to agree to publish survey results. So we'll be asked to publish any responses that we received here to the committee survey for each SL1 after they have been considered by the committee. So if everybody is content with that process, can I ask and seek agreement on the process of moving forward with these new SL1s?
Right.
Okay, thank you. So we're now actually going to move to the new SL1 that we've got in front of us. So that it will be considered during this new process that we've just agreed. So it's at tab 8, page 169, and it also includes the clerk's memo and SL1 itself. Do members have any comments or questions on it? No. Okay, so therefore our members, I didn't turn the page properly. New processes for me too. So, sorry, I needed to read that out. The purpose of the statutory rule. Okay, sorry, I was moving way beyond there quickly. So, tab 8 has the clerk's memo and the SL1 itself, plus the draft statutory rule and EM, exploratory memorandum, as per the new process. So the purpose of the proposed statutory rule is to amend the Health and Social Care Pension Scheme contribution tier thresholds to reflect the recent 25-26 pay awards. These thresholds, based on pensionable pay, determine the rate of contributions members must pay in order to accrue benefits in their Health and Social Care Pension Scheme. Thresholds or band structure are adjusted annually to ensure that the tier thresholds remain up to date and to reduce the likelihood of members moving on into the next contribution tier solely as a result of their pay award. So, I mean, that's the purpose of the statutory rule, and it will be subject to negative resolution. So, can I ask members, first of all, to note receipt of the SL1 and proposed statutory rule, and that these will be published as part of the call for views on the proposal?
Great.
Okay. Can I ask then that members agree that the SL1 will be scheduled for consideration at the meeting on the 5th of February?
Great.
Okay. And then finally ask whether we're content that a briefing from officials is not necessary at this stage?
Great.
Okay. Sorry. And you can see why it was important that I get the page turned. Yeah. Okay. Thanks very much for that. Moving on then to item number 9 on our agenda, which is a written briefing from the department on waiting lists, red flag cancer treatments, and also paediatric waiting lists and PEGS surgery. Can I refer members to the written briefing, page 2 of the tabled papers. I was actually going to suggest, I mean, I'm open to alternative views, given the fact that we had the briefing the other day, but we only got the paper and proposals today. I was going to ask if we could potentially have another week just to review this and come back next week with a fuller focus on it. Dan?
No, that's fine. And we had Professor Mark Taylor on Tuesday, which was helpful. But I must say, they make very, very stark reading. Mm-hmm. They really do. Over 500,000 people still waiting for a first-time consultant appointment in Northern Ireland. And the statistics around breast cancer are still absolutely appalling. And I do... There is talk in this paper, and we haven't got it that long. It's quite a detailed paper, so I accept entirely what you're saying. There is talk in this paper about the funding that was set aside in this year's budget for waiting list, and we know that 74 million of that funding has gone to offset the deficit. And the excuse in this is that we made our programme for government targets, but we still left all of these hundreds of thousands of people waiting on lists. I just find that incredible. I actually find that incredible. So yes, a further examination of this is important, but we have to decide what we're going to do about it, because we've talked about this forever in this committee.
And that's why, I mean, I don't disagree with anything you've said. You know, it is stark reading. We know that our waiting lists are stark, and we need to do something about it. You know, I think we as members just need another week to consider that, so that whenever we come and ask for something to be done about it, that we've thought it through. So, Nuala?
Yeah, I'm happy to wait. Would you mind, Chair, if I just mentioned one of the issues in the report? I think we need to talk about waiting lists as much as possible to scrutinise the numbers, and it was helpful to hear from Mark Taylor, who's overseeing the overall waiting lists, and that there has been that increase to move times down to 8 weeks for breast cancer referrals, but the fact that that's just 3% now seen in 14 days, like, it is good, and it's difficult for us to, congratulate. That is good, but when it doesn't actually help, or it's not comfort to any patients. But I also want to say that something that should be recognised and tribute paid to parents is the paediatric surgery on the PEG tube service, that the waiting list reduced from 92 children in April 2024 to just 9 children as of the 19th of December. Now, I know that a number of those children went private in the end, which is not acceptable at all times. But I know, like, I had met with a number of those parents right from they started their campaign. And I know many of us in the health committee had done the same, and tried to walk with them through the whole process. But I just wanted to just take the time just to commend the parents to that kept going, because, then the 92 down to 9, that didn't just happen in a vacuum. That happened because there was lobbying and pressure, and obviously a great deal of thanks to the clinical professionals who carried it out. But I think it's something definitely worth noting.
I wrote to the department on behalf of a couple of constituents in my own area in relation to that, so I would concur with that. Linda?
I think we do need another week to consider this. I mean, happy to see the reduction in PEG, certainly, but that in relation to other paediatric issues, and I just feel like children are being forgotten about, and this is a lifetime of care that they're going to require because they're not getting the surgeries potentially that they need, and this is going to end up costing our health service. We're just pushing a problem down the road. So I do think we really need to think about what we're going to ask for and what we're going to discuss. I think one of the things that we need to be thinking about in relation to this as well is outcomes. Because waiting lists are figures, and we know what figures mean. We know that it means that people are, individuals are waiting, and we all know because we're constituency MLAs and we're hearing the stories. We're listening to, Dan has outlined around the breast services, women contacting us and their husbands and families contacting us because they're just terrified of what waiting, 6, 7, 8, 9 weeks might mean for the person they love if it turns out to be cancers. But what we don't know is what that means in terms of outcomes, and I don't know how we get to that, or if there's a way of getting to that, but that's one of the reasons I think we need to actually put this conversation off and really look at what we can do, because scrutinising waiting list figures is one thing, but it tells us nothing about what it means.
And some of the discussion next week might be about what other information we need that makes it easier to understand and accessible so that we can do further scrutiny. Colin?
Thank you, Chair, and apologies for coming in to agree with everybody else that we should wait the next week to discuss it and then discuss it now. But I was just, it's maybe on the back of that, because there may be an opportunity to get ahead of this before next week, and that is something about the finance, because it's all well being told this is what the actual number of people on waiting lists is, and this is the number of people that are being seen. But if we're not told by the department how much they actually need to fix it, and I do think that that's a broader conversation that the public need to know, how much money is not being spent on waiting lists that needs to be spent on it to fix it out. And apology to all those present that are, but that's maybe a wider conversation for the whole executive, because I'm quite confident that if it was in Wales, it would be all members of the Welsh Government that would be standing up and taking the flak for waiting lists, and the same if it was in Scotland. But whenever it comes to here, we simply point at one minister, and I think that maybe if we knew how much money was needed, we would know how much money they don't have, and then we will know how much needs to be asked to be able to resolve the situation. So that financial background to the actual cost of fixing the waiting lists, I think, is a really important piece so that people can understand and know that themselves.
Yeah, I mean, not to get overly political about it, but I mean, my recollection is the health minister asked for 215 million during the programme for government discussions. The executive gave him the 215 million. As Diane points out, some of that is now no longer being spent in relation to it. But there's a number. I mean, we have a job as a health committee to hold the minister to account. I mean, there's nowhere more important in that role than with regard to waiting lists, particularly, and we have identified it, particularly red flag, because these are the most important waiting lists, they're life and death. So I think we'll all have to read and reread what we've got and have it clear in our head what we want to do next week moving forward. Danny?
Can I just ask briefly one thing? I know we've asked this a couple of times. I don't think we've ever got an answer on it. When waiting lists do go down, we don't seem to be clear on how many of those people, and Nuala alluded to it there, have went privately, who have come off waiting lists, who have become too frail for the operation they're waiting on, or even passed away on the waiting list.
Were in fact diagnosed with cancer.
Yeah. So is there any way we could write to the department and ask, and we know that private medicine in Northern Ireland is booming. I know constituents who are spending huge amounts of money going for procedures, but they're obviously coming off waiting lists, but we don't really have any way of measuring that.
Yeah, I think, I don't see any reason why we couldn't, in advance of next Thursday, just write for that. Okay, members, so correspondence, can I refer everybody to correspondence in the main pack, page 186, including correspondence index at page 189, and correspondence in table papers as well, including an index paper at that. I just wanted to start because I got it added on to the table papers this morning. I got a letter from Trevor McCartney from NI Hospice just about engagement that they had with the department in relation to the commissioning and cost of beds between the specialist service of palliative care versus, and we discussed this at length during our committee, and we come up with a recommendation in our own report. People will only maybe got the letter today, but it's very, very disappointing that the conversations that they have had with SPPG in relation to this, where the SPPG seem determined that the cost of a bed is the same as it is in secondary care. And we clearly know that's not the case, because even within the department they're paying much more for that in their own palliative care beds and Antrim. So I'm not maybe suggesting anything now, because we still haven't got our response back from the department in relation to our report. It might be worth waiting to that, but I'm just kind of flagging that we've done an awful lot of work. I think everybody in this committee will expect our recommendations to be taken seriously. I'm a bit disappointed at a very early stage that seems to be the attitude of the department.
Chair, in one of the responses in the chamber, we heard something along the lines of initiating a review. I was like, we've done it. You're going to initiate something that we've done. We're handing it to you. We spent hours. Officials have our clerks have done so much work on it. We have actual evidence, so I'm not surprised at all. Yes, they might not be able to fix it now, but don't provide a wee bit of false narrative by saying we're going to do a review just to kick a can down the road. Just say, look, we want to do this. We recognise it. You're right. It just can't be done now.
So Gerard Cassidy, in one of his appearances at the committee on this issue, actually said that after we had decided to do the inquiry into palliative care, that he was actually going to do a bit of an assessment of what palliative care was offered. Mm-hmm. Has anybody ever seen the assessment of that piece of work? Because I think we should ask for that. And I respect the fact that you said that we need to wait until the department respond, but we did say in our recommendations that if the department didn't want to take any responsibility, the committee would consider legislation.
Oh, absolutely.
I think that's really important to put on the record.
I think it's important that we go back to Trevor, say we got a letter, we're very disappointed, and I also think that we should consider forwarding that to the department and saying that we really are hoping for their response as quickly as possible, because this is an important issue that can't be put in the long finger. Okay, other correspondence then. So we've got a letter from the NI Assembly Engagement Office about the Health Committee's participation in the Balmoral Show this year, and that's at page 336. So I don't know if members have any commentary on that. I was going to suggest that we maybe ask the committee staff to come back with some options. There may be options to hold a committee meeting there. There may be options for an hour, a couple of hours of engagement on a specific topic or issue. So if people are happy. Sorry, probably should ask, do people think it's a good idea before we commit the staff to doing work?
Yeah, why not?
There's a lot of people who go through the Balmoral show. Health is the biggest issue. People up there, I mean, primarily there for agriculture and a bit of crack, but you know, it's an opportunity for the public to engage with politicians, and health is the big issue. So, happy enough then that the committee staff come back with some recommendations or options. So, also, members, there's correspondence from SOAS at page 537 on our visit to the southwest. I'm just wondering if anybody, we're still awaiting some responses from the department and the trust to queries that we raised at that briefing on the 27th of November. So I'm just, are people content that we?
I think we need to wait for the responses on that one. I don't know how others feel.
Okay, so are members content then just that the suggested actions in the correspondent index at page 189 of the main pack and page 14 of the table pack are that we move forward with that? Nola and then Orlea. Go ahead.
No, I'm not happy, but not unhappy with the staff, don't worry. 10.4, poverty of young care home residents. And the response was, you know, the individualised personal payments to people living in care homes, and it says young care home residents. They're actually over the age of 18, and the department has just come back and said, oh, that's a matter for the DFC. When we had, during the learning disability framework kind of consultation, we had a number of them up here, and like, it slipped my mind, unfortunately. I can't remember his name. He would come quite often to committee on the is it Nigel? I think it is Nigel. No, Nigel's the really younger one. But anyway, we can get the name. But they said specifically when we raised that, they agree that actually the amount given to residents might not be enough, and we are looking into reviewing that. I tabled a written question because I have wrote to the department on this before, around where the line is drawn, because this is managed sometimes not by family, and in the most case by staff. So I don't understand why it looks like they're washing their hands of it, when we were told in committee that yes, we agree and we're looking at this. So I wonder if we can perhaps, as an added to, follow up that with the department. I've already tabled a written question, but given it was actually said at committee that, you know, we are looking into whether that is actually enough, but now we're being told, well, actually that's just a matter for the Department for Communities.
Anybody unhappy with that?
And
go ahead.
My other one was 10.13, and it was the PATH unit that we all visited at the Mater Hospital. I just wanted to put on record that it was a fantastic visit. Learned a lot, and within it here, for people who don't know and who weren't able to attend, you know, it's almost like a step between inpatient and A&E for those who are suffering from mental health stress and need emergency care. And this was an initiative that was set up by the people within the Mater Hospital themselves, and we all saw that it was excellent. It said in here the funding required to operate the service in 25 to 26 is 1.4 million. And all trusts are experiencing significant pressures, etc. But I don't believe this is a budget issue, because actually these people are going to be treated anyway, but they're going to be treated in a differing part of the hospital with not the same level of experienced staff, because you can't, it's an A&E. So I do wonder if that is actually a very kind of difficult letter to take, that the funding case is this, and actually that's really just saying, well, we don't have enough funding, so we're not going to do it. It potentially is providing a bit of fear on something that is already existing within the Mater Hospital, as far as I know, will continue to exist. And if it didn't because of this 1.4 million, still be spending it by being in another part of the hospital. I'm not sure what we do in that. I'm concerned for the way that response is laid out.
Danny, you wanted to come in on that, or Troy or Leah, you want to come in? Go ahead.
Bring Danny in first.
Go ahead.
Just with that, yeah, I would concur the visit was fantastic and it was a brilliant unit. But in fact, there's quite significant savings there because a lot of those people were discharged without further care being needed. So there's a cost, but there's an offset there as well, that a lot of, they were discharged home with the intensive support that they got, and they wouldn't have needed further follow-up care. So there was a huge saving there.
So, and I mean, this isn't something that came into my head, so I'm going to thank the committee clerk for alerting me to this, but we have this conversation an awful lot about the department making something, saving potentially, but as of cost in some other aspect of it. I think we should write to the department and ask how many health economists they have and how they make, how they score decisions about whether they fund one service or don't fund that service, so that we know how they do it, so that we can know how they do it, because I mean the last thing we want is decisions being made in our health service purely, and excuse my terminology, by bean counters, but by people who are only looking at, we don't have that money. I think our health service decisions, and the minister should be advised by, at the very least, health economists who are able to say to him, well, if we make this decision, it costs this, but here's what the saving will be down the line, or here's the impact that it will have on patient outcomes. So, I mean, I don't know if the department has that, if that is factored into any of the decisions that the department makes, but I'd clearly like to know that.
Hiding behind your figures for inaction on a lot of it, and I mean, that's what we see a lot of the time.
So are people okay if we write to the department just to ask what the situation is with health economists in terms of decision making within the department? Leah?
Yeah, and no, I'm content with that. And just to bring it back to the path, and I should have, because I do think this is one of the good examples in terms of even how difficult it is as a scrutiny committee to unpick where money goes, how's it spent, and how efficient is the spending in terms of the savings. And but the path, when we were out that day, I think the figure was 40% of the patients that they are actually looking after, then because of the care they're getting in that sort of temporary unit, means that they then don't need to go on and get a bed in an inpatient psychiatric ward. So already it doesn't, even if we can be given the cost breakdown of that. So if they're saying 1.4 million in the business case isn't achievable, because I was really disappointed with that response, given the hugely positive impact that service is having on mental health patients. First and foremost, they're not stuck in the environment of the emergency department, but secondly, some of them are actually receiving the treatment that they require at that present time, that then they don't need to go on to a mental health unit, and how do you even put a cost onto some of that? So I definitely think that we should respond to try and get a fuller breakdown in terms of, rather than look, due to budgetary pressures, we'll probably not be able to fund the 1.4 million. Well, what's the cost of not funding it, and what's the cost of the beds that are being made available and freed up for that 40% figure who don't need that inpatient treatment? So I have another 3 items, if I can just quickly. The other one, the 10.3 was a response around, the committee had inquired about the integration of primary care into Encompass when the minister was with us previously. So the letter had come back saying we had requested a timeline, basically that it can't be done. It's too complex and it's largely unprecedented to have your primary care, your secondary care and your community care all integrated into one. So the letter goes on to say that there are some proposals to enhance digital services subject to funding. That's digital services for GPs. And then they offered that the Chief Digital Information Officer, Dr. Paul Rice, that he would make himself available to come and brief the committee. And to be honest, I think, given the amount of money that has been spent on Encompass, and I don't know, was it ever considered at any stage before the rollout of Encompass, when Encompass was being designed, to try and incorporate the primary care in with secondary care? If not, why not? And it's only now that we're sort of being told, well, it can't be done, it's too complex, and it's largely unprecedented. But what does that mean? Because the conversation that we had with the Minister when he was here about the digital, incorporating the digital systems, was around assisting the rollout of the neighbourhood models. If you're trying to shift everything left into the community, you know, now we're just being told, well, it's too complex, you can't integrate the digital systems. And if you think back to the committee session that we done in Le Mans Hotel, and we had that briefing around how you try and, you know, basically deal with all the blockage in the system and try and treat more people in primary care. I can't remember the guy, the MP who presented, but he had mentioned around the importance of how you try and deal with your budget and make savings, and the importance of that digital element. So I definitely just think it's something that maybe as a committee we might want to maybe accept the offer of that briefing and try and tease that out a wee bit more. The other one on 10.12 was the flu vaccine uptake. So it's sitting at 27%. In previous years, it only reached 21% in the previous 2 years. So in a way, 27% is good. That is clearly up on previous years. But also, it's only 27% of health and social care staff. So something is not working here. You know, I think that we should go back and actually request what is the absentee levels within our health and social care staff over the winter months, you know, due to them and getting sick. What impact is that having on every winter, time and time again, on health and social care services? And given that, what else is being done to try and get those vaccination levels out of the 20s and up to the 30s, 40s, 50s? Surely there's more that can be done. In the letter it mentions some good stuff from the PHA and about, you know, PR and, you know, promotion. But we need to do more than that. And I know that there was, when we were in the path that day, there was a nurse on site because we were obviously receiving our vaccinations as well. And she says that there was staff then put on to the wards to vaccinate staff during their working hours. I know we had referenced that whenever we wrote off to the Minister. It wasn't mentioned in the response. But I just think more needs to be done there from a departmental level. And maybe even if you start now in advance of next winter, you might get those vaccination levels up. And then just finally on 10.15, it was on the substance use strategy. And again, we had it down just a note around, you know, due to, you know, it'll be considered in the next budget in terms of what funding can be given to that strategy. The breakdown of that letter, we were trying to get the breakdown of the funding first and foremost, the 30 million that's gone into the substance use. There was some numbers, some breakdown that was given, but again, I don't think not enough in terms of the €8 million money that's coming from Peace Plus. That's around the alcohol detoxification services. So it's saying that's due to roll out. Delivery is due to begin in the second half of 2026. Yet we requested a breakdown of where that €8 million is going, and it hasn't been provided. So just if we can go back on that, please, and just try and drill into a wee bit more detail around that.
Okay, everybody content with those suggestions? Mm-hmm. Linda, were you looking at?
It's actually been covered. If we're going to get the briefing on Encompass, I had a couple of points to make, but just to say, we were briefed by the department on Encompass whenever the Assembly was down, the health spokespersons at that time, and I did say this, I raised it then about how they were going to integrate it with primary care, and it was waffled over that there was, you know, they were looking into that, how they were going to do that. Certainly didn't say it would be too complex or couldn't be done. And I had said at that time, what is the value of this if we cannot get it? And it's just another example of how primary care, all the talk is about shift left and how important GPs are and how important it is that people are seen by GPs so they don't end up in secondary care. But we're doing nothing. Well, I wouldn't say we, the department is doing nothing to actually ensure that primary care is given that focus and that they can actually be part of the system in order to keep people out of secondary care.
Okay, everybody content? So with those amendments then we're agreeing the table of contents. Forward work programme, members. So draft forward work programmes at page 578. Everybody content with it?
Yeah.
AOB, any other business? We
No.
kind of do any other business throughout the meeting. 13, date, time, place of next meeting. Next meeting's next Thursday, 22nd of January, room 29. Thank you very much.
Committee Room 29. Sound. 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 Committee Room 29, 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 Sound.